Thank you very much, Dr. Aspett. I want to start by acknowledging Kristen Ann Carr. Rarely have two people, David Marsh and Barbara Carr, turned a tragedy into a 20-year plus exercise in helping other patients following the untimely death of their daughter. Not only have they raised a lot of money for research, they've supported patient advocate groups, they've been patient advocates themselves. And I just want everyone to acknowledge that that's a tough thing to do, to have a true tragedy and have the courage or even the resilience to turn that into a triumph for others. So, David, thank you. So, yes, I am going to... So I wouldn't have been able to give this talk last weekend because the American Surgical does not allow you to give data that's not been presented before until the meeting. But fortunately, a day, 48 hours ago, I gave this paper at the American Surgical. So what I'm going to do is to take this, which was a relatively brief talk, and expand it a little bit. But those of you who were there, I apologize. There is certainly the backbone of the talk is what I showed the other day. Now, the term soft tissue sarcoma, as you heard, and I again apologize if I repeat some of the things that Steve said, but that's okay because most of us need things repeated about 5 times before we learn them, so it's okay. So the term soft tissue sarcoma, it encompasses a great deal. They can occur in any site, as was alluded to. It's difficult to know how many histological types. The best estimate is that there are about 80 histological types. Depends a little bit on how you describe those. Of those, 50% have a marked propensity for metastasis, and the other 50% show local aggression with much more limited metastasis. And most, but not all, have a benign counterpart. As Stephen said, they're rare, they're uncommon. I just want to make sure I don't go over time here. And in the thesis is that in rare tumors with multiple variable sites, variable histology, variable presentation, you can only develop consistent management plans if you have a very strong data set to work from. And so that was our... What the hell am I doing here? You can't use the mouse. Yeah, okay.
Let's get rid of that. The mouse doesn't work. Okay.
All right. So the thesis was that if you have rare tumors, the only way to develop management plans is, in fact, to have good data sets. And the argument was that if you have well-documented prospective data collection, underline the prospected, spread over decades, we'll actually begin to understand the disease. The other advantage, of course, is that you can take tumor and germ cell, normal tissue, at the time of the procedure, and if you link the analysis of that tissue to the clinical databases, then you have a very powerful resource. So in July 1982, we began a prospective soft tissue sarcoma database. Criterion for entry was admission to the institution for a surgical procedure. Now that's a deliberate decision, because when you begin a database, of course, you have to have some entry criteria. And the key for us, of course, was that we would have available tissue. So we took those that were having a surgical operation. That meant, though, that we included people who came with a primary tumor, one that had never been treated before, a local recurrent tumor, already had treatment and recurred, or indeed metastatic disease that we were planning on operating on. All the patients have been reviewed initially weekly and now bi-weekly at a multidisciplinary meeting. We've conducted those meetings for 30 years, so it's a huge commitment of time and energy. It's very important for those of you who are thinking about developing any kind of database If you're not willing to commit a minimum of 3 years when nothing is gained, don't start. Too often I've seen people say, well, I'm going to leave Memorial Sloan Kettering, I'm going to start my own database, and they rush off to another institution and draw up something that contains 400 pieces of information on 12 tumors, and they wonder why it fails at 6 months. So the cautionary tale is start simple, start focused, but stay with it. To make these databases of any sense, they have to have continuous follow-up. And the follow-up depends on what you're looking for. Are you looking for a local recurrence? Are you looking for distant recurrence, metastasis? Or are you looking from death from the cancer? Or are you looking to overall survival? And each one of those will have variable presentations and variable factors that predict what happens. So the aim of my talk the other day, and part of the aim today, is to convince you that such databases can provide not only outcome, but actually knowledge. And that knowledge will base your clinical management. So in the 3 decades, July of '82 to May of 2013, we entered 10,000 patients into this prospective database. Now, did I think I'd live long enough to enter 10,000? Absolutely not. But if you don't start, you won't finish. What about some of these results? And you saw some of these alluded to by Dr. Katz. First of all, outcome by sight can actually convey biology and direct management. What do I mean by that? What I mean by that is that as men and women present equally, we don't have to correct for sex, and this is sex, not gender. The distribution is clearly shown here. The local extremity and the upper extremity combined have about 40% of all tumors. Retroperitoneum, as Dr. Katz alluded, 16 to 20% based on these 10,000 cases. Does this work? I'm going to use the mouse for a moment. Just a minute. Yeah. Yeah. This just says that, of course, the commonest site is actually in the thigh when you look at the extremity, and presumptively that's because it's the dominant site of all the mesenchymal tissue that you have in your extremities, and so that's much more likely. So if you begin, as I've suggested, to examine outcome based on the site as one example, and I'll show many other examples, then in fact you can learn something about biology. What do I mean? Well, if we look at this slide here, you can see this curve. Just look at the purple curve there, and that's labeled visceral, about 2,000 cases. The retroperitoneal one, again, almost 2,000 cases. Very different local recurrence rate. These people have, at worst, a 20% local recurrence, and these people here have something more like 60 to 70%. And what's also important is, of course, when we began, we thought everything would be over at 5 years, but you can see that these patients continue to have local recurrence out over 20 and 30 years. And if we'd stopped there, we would have known very little about it. So this is the local recurrence for these patients. But when we look at those same two curves for disease-specific survival, death from sarcoma, the purple line is now down here, and it parallels the red line. And what that says, of course, is that the patients who are sitting on this red line for local recurrence, the previous curve, with local recurrence, tended to die from local recurrence. They had some metastatic effect because it's lower than the previous curve. The patients in the purple line, the visceral ones who had a local recurrence up here, are dying essentially of their disease in a very similar fashion to this other curve. So what does that tell us biologically? It says this red curve is a local recurrence problem. It usually requires a local therapy. This curve here is a systemic recurrence. People are dying of metastatic disease, so they require a systemic solution. So just by following these patients and carefully characterize them, we've actually learned a great deal about the biology. Histology, you heard my suggestion there are at least 80 subtypes, all of which are thought to have a benign counterpart, we know for sure the synovial tumor is not arising from synovium, and I'll illustrate that in a little while. And you've heard that the common tumors are liposarcoma, leiomyosarcoma, and this undifferentiated sarcoma. And I've listed here that these are dynamic. The histology isn't necessarily consistent. When we began this undifferentiated pleomorphic sarcoma, we called it malignant fibrous histiocytoma. It was malignant, it was a little bit fibrous, but it had nothing to do with histiocytes. And most of those now belong in this area here, although some will belong in the fibrosarcoma. GI stromal tumor didn't exist when I began this database. We first of all called those leiomyosarcomas of the small intestine, then we called them gastroautonomic nerve tumors, which was getting close because that's presumed the source from the Cajal cells. And then we called then we realized that they had a particular signature, which you heard about, with a surface marker, and we could make that diagnosis. Again, Steve alluded to this, but this is perhaps a little more updated, that if you know about the histopathology, but if you know about the site, then in fact you know about the histopathology. And the common tumors in the lower extremity are the liposarcoma and the undifferentiated tumor, whereas if you look at all the visceral tumors, most of those, as you heard, will be GI stromal tumors, and that will define them. But you can, in fact, take that further, because, as you heard, we often use grade as a surrogate for the minimal numbers that we have for individual. And grade, along with size, are good surrogates for histology and good surrogates to teach us. For example, recurrence by grade, about 2/3 of tumors will be high grade and about 1/3 low grade. That's in all parts of the body. If you look only at the primary extremity, the people who presented to us at most with a biopsy, often not with a biopsy, but no treatment, then the disease-specific survival, the death from disease in the high-grade tumors approaches 50%. And again, you can see that while the majority happen in the first 5 years, they continue to have late metastasis out to 20 years. And that's the advantage, of course, of looking at disease-specific survival. If we looked at overall survival, a lot of the old patients will die during that time of other causes, and we wouldn't learn anything. What's also significant, though, these patients with low-grade tumors have, in fact, a late death, which implies that, as I said, even some of the low-grade tumors, while locally aggressive, also have the potential for metastatic disease. And that's illustrated here. I just showed you the exact same curve as local recurrence, as systemic recurrence. And again, you can see the local recurrence rate is similar, close to each other, but the death from disease is quite different. Again, telling us about these people in the blue line presumably need more than a local procedure. They need some systemic treatment, whereas the patients who have the low-grade lesions, one wouldn't want to do that. And of course, what that also says is this would be a very, very strong argument that we should not be amputating when in fact local recurrence is only 20%. And I won't have time to talk about that, but one of our earliest seminal studies was to show that amputation, while it solved the local problem, it did not change the systemic disease. And in fact, when I started, amputation was the standard treatment. And the only way we were able to do that trial was to actually say to the patient, I appreciate that this comparison between a simple operation and an amputation, but if you go back home, you will get an amputation. That was the only thing that allowed us to be able to do that study. And I'm repeating myself, that says that local recurrence is associated with, but not causative of, disease-specific survival. Because otherwise, everybody who was amputated, who couldn't locally recur, nobody would die. And of course they do. Size is an important prognostic factor. If you look at all comers, about a third of each are less than 5 to 10, or greater than 10 centimeters. If we look at the extremity, when it's easier to actually measure that, again, the distribution is about the same. 1/3 small, 1/3 medium, and 1/3 greater than 10. The problem is all our staging systems have historically said less than 5 or, less than or greater than 5 as a marker. But when you look at the primary extremity, you can see that the less than 5, the 5 to 10, and the greater than 10 are clearly different in terms of death from disease. So a small tumor has a less like. And if you look at the high-grade ones, the ones that have this propensity or this ability to metastasize, that differential is even greater. And of course, that says that lumping these two together is quite imprecise, and that we need to do this. Now, this is almost certainly arbitrary. It's a continuous progression. Tumors don't grow from 5 to 10 to 10 to 15. They grow 5, 6, 7, 8, 9, 10. And we could draw curves that essentially parallel that. Prognostic variables are not independent. What do I mean by that? Well, here we have disease-specific, death from disease, by size and depth. Once you have a tumor that's greater than 5 centimeters, then the influence of depth disappears. It still exists here, less than 5 superficial, greater than less than 5 deep. And of course, these ones here, the superficial, greater than 5, they'll be small numbers because it's hard to have a tumor 5 centimeters greater and still be superficial to the fascia. It occurs, but the grade dominates it. Recurrences are time and grade dependent. What do I mean by that? If you look at distant metastasis for all extremity lesions, you can see the high-grade lesions have a rapid, those that are going to metastasize, the majority, again, probably 2/3 in 3 years, metastasize in that first 3 years. The low-grade tumors have metastasis that continues out over a lifetime. And once we get out here at about 10 or 15 years, you can see these two curves tend to parallel, again reflecting almost certainly the inherent heterogeneity of the initial tumor. The other point that I made and emphasized strongly, that this prospective collection of tumor and germline tissue, early on, of course, we only collected tumor tissue. We didn't know that we should be looking for germline material. We never dreamt that we would have the ability to analyze the genetic makeup as much as we do now. But of course, it also does other things. It not only allows the molecular analysis, it allows us to develop cell lines, and it allows us to develop in vivo animal models. And Dr. Sam Singer, who took over the program project that we initiated, has a very active laboratory looking at those issues. What are the consequences? Well, I mentioned this tumor, the synovial sarcoma. Historically, it was labeled that because it was a disease of adolescents and young adults occurring in and around joint extremities. And we wouldn't make the diagnosis but from that. We learned it had nothing to do with synovium, but we didn't know what it did have to do with it. And then this fusion gene, Mark Ladani, a pathologist at our institution, we learned that the fusion gene, the SYT-SSX, is a diagnostic molecular signature for synovial sarcoma. Some have argued that the type of fusion makes a difference. We wrote a paper that said it did. It might. It's minimal. But what it does do, of course, is then it says, now we make the diagnosis with precision. And what's that mean, of course? It means that I told you it was a disease of young people, of young adolescents, but you can see it occurs throughout the entire spectrum of life. Something we just never would have done without that molecular diagnosis. And if you look at the distribution of these tumors by site in the body, you can see it's widely. Yes, it occurs in the upper and lower extremity most commonly, but you can see it occurs in many other places. And in fact, I've listed, it just says the same thing. I've listed here some of the unusual sites where we've made the diagnosis of the synovial sarcoma in heart, diaphragm, pleura, prostate, brain, all places where there was no possible association of that original name. But no one's thought of a good enough name to change it. So the conclusion of the presentation I gave the other day was that in rare diseases, long-term prospective databases provide natural history, prognostic factors for outcome, guide management, provide tumor and germline, and significantly change management from discipline-specific to disease-specific. What do I mean by that? Discipline-specific is treatment by the surgeon, the radiation therapist, the medical oncologist, discipline-specific. Often organ discipline-specific, head and neck, ovary, limb. And we now know that's not how we should approach disease-specific. The patient wants someone who understands their disease. Now let me add to some of those observations, because when I began to analyze this data, obviously I had far more than I could do for a single talk. First of all, another pattern of metastasis guides treatment. Does the patient have a tumor that goes to lymph nodes? Well, as it turns out, lymph node metastases are uncommon. 15% maximum of all patients, and lymph nodes alone as the only site of metastasis, certainly less than 10% and probably closer to 5%. So lymph node dissection might be of value in the 7% that only have lymph node metastasis, but it won't be of value to the others that have it in combination. And that's just illustrated here. You can see that we rescue a few people. Look how few numbers there are there. A few people by doing a lymph node dissection, the blue line here. Again, you can see these metastatic disease occurring 10 and 15 years out, and we've barely got halfway down the curve by 5 years. Site and histology can predict the metastatic pattern, not just in the lymph nodes as I described to you, but in fact it can tell us how to follow patients. It can tell us, for instance, that if you have an extremity lesion, the commonest and primary site of your metastasis will be the lung. A chest x-ray, maybe a CT will suffice. We go to the visceral tumors, the GI tumors, just will go to liver. But the same visceral organs in GYN tumors are not, in fact, going to liver, but in fact are going to the lung. So on one hand, we're looking at the visceral GI tumors, and that's a CT scan looking at the liver. On the other hand, we're looking at visceral GYN tumors. That's evaluation of the chest and thorax. A few comments on the retroperitoneal lesions, and then I'll sum up. Overall, as I showed you before, disease-specific survival for all retroperitoneal tumors. Complete resection dominates outcome. But there are people who have an incomplete resection who can survive 5 and 10 years. And those people will be people that we will try to palliate. But again, complete resection. And you can see I've listed R0 or R1. And Dr. Katz alluded to that. R1 being microscopic disease at the margin. But it's really the complete gross resection, and the microscopic margin is much less relevant in the retroperitoneum than it is anywhere else. Now that's multifactorial too. It's that idea of what is the limiting point, the idea that he made. We don't take out the vena cava because if the tumor is sitting on the kidney. We just don't do that, and we've not shown to make a difference. It's important that in all retroperitoneal sarcomas, the first operation is the best, invariably. That if you have a local recurrence, you still can be salvaged. These are people who have come back with a local recurrence, and that this is their disease-specific survival. So you can salvage people from death with an operation. Once metastasis is present, there's isolated patients that we'll salvage, but not very many. First operation's the best operation. Don't give up on the local recurrence. There are a few people we'll salvage with metastatic disease. Once the complete resection is performed, again, the biology dominates. The the likelihood of them dying, just as we saw in the extremity. A low grade, much less death from disease, but still significant, whereas the high grade tumors at 15 years, 80% will have succumbed to their disease. Disease-specific survival by margin. I told you the R1, R0, and here is the overall data, just showing it that didn't change the disease-specific survival. Now be very careful, we're not arguing for an operation where we leave tumor behind deliberately. That's the R2 resection. Very few of those people ever survive. What we're arguing for is that we balance these few microns against the morbidity of what we do. We thought for a long time that liposarcoma behaved quite differently, but of course there are so many factors, and so once we add in the greater than 5 centimeter, the high grade, the complete resection, then in fact liposarcoma behaves similarly to other retroperitoneal sarcomas. And this says essentially the same thing, except that the local recurrence rate may be a little worse with liposarcoma. Again, something that I alluded to. I think I probably have said more than enough. Again, here's the one piece of evidence that you could use to support doing more, getting the R0 above the R1 resection. That is, this slide says disease-specific survival, there's a slight benefit to have an R0, but as Dr. Katz alluded to, this is all patient selection, because once you correct for all the other variables, there'll be no difference. So this has been an exciting time. I want to acknowledge again the Kristen Ann Carr Fund, multiple colleagues, and of course 10,000 individual patients. This is not just a data set, this is a small village. Thank you very much.